In this lecture, we are going to look at the components of the EKG complex. We will begin by defining what a wave, segment, and interval are, and then proceed to look at each of these aspects of the EKG complex. So let's first begin by defining a few basic terms, as they will help prevent confusion. First, a wave is a deflection from the baseline that represents some cardiac event. So if you imagine here, this is our baseline. In any deflection, here we have our first deflection going up in green, and this P here is our P wave. And as we said, that's a cardiac event. The P wave, as we'll learn, represents atrial depolarization. Next, we have the segment, and this is a specific portion of the complex. For example, the segment between the end of the P wave, so the end of the green, and the beginning of the QRS complex, here in red, which represents, we'll say, ventricular depolarization. This is called the PR segment. Finally, we have an interval. And an interval is the distance measured as time occurring between two cardiac events. For example, the time interval between the beginning of the P wave, so as we said here, the beginning of atrial depolarization, and the beginning of the QRS complex, here in red, which is the beginning of ventricular depolarization, makes up an interval. Specifically, this is called the PR interval. Now that we have those definitions aside, we're going to look at each component of the EKG complex. And first, we will begin with the P wave. So here's our P wave, and as we mentioned, this represents atrial depolarization. And you'll see here on each slide, there's some key points that will help you, and they're important to note and write down as we move forward. So we said the P wave represents atrial depolarization, and this begins when the SA node fires. It also includes the transmission of the impulse through the internodal pathways, the Bachmann bundle, and the atrial myocytes. Now, if you're not familiar or don't recall the route of electrical transmission in the heart, review the lecture entitled The Heart and Its Electrical Conduction System, and that will get you up to speed. And so we see here the normal duration of the P wave, so from here to here, is 0.08 to 0.11 seconds. And its axis, which we'll learn more about axis in future lectures, is directed downward and to the left between 0 and positive 75 degrees. So for now, just take down these notes and you'll know what they are as you watch the future videos. Okay, so now let's move on to the TP wave. The TP wave represents atrial repolarization, and it deflects in the opposite direction of the P wave. So again, here's our P wave deflected upward, and here's our TP wave deflected downward. And you will often not see this TP wave because it occurs at the same time as the more powerful QRS wave. So here's our QRS complex, and it usually obscures or buries this, so usually you won't really see it. Sometimes you can see it if the QRS complex is absent. For instance, you may see a TP wave in AV dissociation, non-conducted beats, or as PR depression or ST depression in very fast sinus tachycardias. Okay, so we talked about the P wave and the TP wave. Now let's move on to the PR segment. And this is the portion of time between the end of the P wave, so again, here's our P wave, and the beginning of the QRS complex. So we said here, this is our QRS complex. And as we showed when we were defining the PR segment, this is it right here. And this represents transmission of electrical depolarization wave through the AV node, the His bundle, the bundle branches, and the Purkinje system. Now the PR segment is often found along the baseline. So remember we said this is our baseline. So you can see here it's usually along the baseline, but sometimes it may be depressed. If it's less than 0.8 millimeters, it's normal, but anything greater is pathological. For example, the PR segment can be depressed in pericarditis or with an atrial infarct. Here we have the PR interval, which represents the time from the beginning of the P wave. So as we've been showing, this is the P wave, so the beginning of it. And that is, so the P wave is the initiation of the electrical impulse in the SA node to the beginning of the QRS complex. So that's the beginning. Remember, we said this is the QRS, represents ventricular depolarization. The P wave represents atrial depolarization. So you have from the beginning of atrial depolarization to the beginning of ventricular depolarization, which defines an interval of 2 different cardiac events. That is what we call the PR interval. And the PR interval, it includes the P wave as well as the PR segment that we just defined. And the normal duration is 0.12 to 0.2 seconds. If it is less than 0.12 seconds, it's considered shortened. And if it's longer than 0.2 seconds, it's considered prolonged, and this may represent AV block, which we'll discuss in future lectures. You may hear the term PQ interval. Now, what is the PQ interval? Well, the PQ interval is the same as the PR interval. However, it may be used if the first wave of the QRS complex, so this is our QRS complex, is a Q wave. And we'll learn about Q waves. That's the first deflection of the QRS complex if it goes down negative. So this is really the same as the PR interval. And sometimes you may just hear someone say that. It's just something to be aware of, and that's pretty much all you have to know on that. Okay, now we get to the QRS complex, which we've been saying represents ventricular depolarization. And the normal QRS complex duration is between 0.06 and 0.11 seconds. You may sometimes hear 0.12 seconds. Right around that is what the duration should be. And its axis is usually directed downward and to the left between -30 and positive 105 degrees. Let's go over an area that commonly gets confused, which is how to properly name the waves in the QRS complex. We said earlier in the lecture that a wave is a deflection from baseline. Look at the image on the left and notice how the QRS complex has deflections going off baseline. So here we set as our baseline, and first one coming down is known as the Q wave of the QRS complex. So this whole thing here is our QRS complex. The first negative deflection is the Q wave. The first positive deflection is the R wave. And the first negative deflection after an R wave is an S wave. So as you can see, the QRS complex is a combination of waves. The waves are named according to size, location, and direction of deflection. The tall or deep waves in the QRS complexes are given capital letters, while the small waves are given lowercase letters. However, this standard is not always followed, so don't be surprised if other books or instructors don't use it. If we try to name this QRS image here on the left, let's see how we would name it. Well, this first Q wave is a small one, so we said small waves will get the lowercase q. And here, this is a big R wave, so it'll be a capital R, and this is a small S wave. So we would call this, or write it like this. So a small q, big capital R, and a lowercase s wave. Okay, so you can also have some changes in the QRS complex that can affect how its components are named. Look at the image here on the right. First, note that there are no Q waves in any of the 5. This is because a Q wave is defined as the first negative deflection after the P wave. And each deflection in the image starts off with a positive deflection, which represents an R wave. So what we have here is, imagine we have a P wave. The first deflection that goes down, if it goes down negative, this is considered a Q wave. And then the first positive deflection after the P wave is an R wave. However, in this image here on the right, we have imagined a P wave, and then each one is deflected up. So these are considered R waves. So again, we have a P wave. This is our P wave. The first positive deflection, if it deflects up, then it is called an R wave. Again, this is a P. Now if we have a P wave and it deflects down, so in the negative direction and then back up, this first negative deflection is a Q and this positive deflection is an R wave. Now know how the complex in this upper left image, so this here, has two R waves, this R wave and this R wave, which is called an R prime. And it's just called an R prime because it just represents another R wave. So just for nomenclature reason, we know that the first R is called an R, and the second R in the same QRS complex will be called an R prime. Now if we look at this image next to it, so this one here, we'll see that the initial R, so this initial R, is a lowercase r, and as we said before, this is because this is a smaller R wave. And again, notice how the next R in this QRX complex is R prime, and capital R because it is a big R wave. Now this one here on this far right is similar to the one in the middle. You can just see that the smaller R wave comes after, and again look, it's smaller r and it has the prime because it is the second R wave in the QRS complex. Okay, so hopefully you're starting to get the hang of this. Now let's look at these next few. Well, first of all, let's note that an S wave is considered the first negative component after an R wave. So if it's the first negative component after an R wave, then why are there no S waves in the top row of the complexes? So you can see here, none of these top ones have any S waves. You can see some here in the bottom, but none are in the top, even though they have some negative deflections. And this is because the S wave only applies to a negative component of the QRS complex that falls below the baseline. So here's our baseline. Note that none of these fall below the baseline. And if you look at the bottom ones, you can see how they're falling below the baseline and therefore considered S waves. Okay, so just a heads up, while this is technically the correct nomenclature, the norm is still to call these QRS complexes. Okay, so let's look at these bottom two complexes quickly. So again, the first deflection upward and going in the positive direction is an R wave. And this time we have a negative wave that is coming down and crossing the baseline. And this represents an S wave. So there's our S waves. Then we have a large positively deflected wave that we will call R prime, so it's coming back up, positive, and we were going to call this second R wave an R prime. And again, R prime just because it's the second R wave in this QRS complex. Now in this final one here in the bottom corner on the right, again, this has the same initial RS R prime sequence as the one to the left of it, and then it has an additional S wave that comes back down here, and you can't really see it, but that's also an S prime. So just like there's two R waves, the second one being called the R prime, here we also have two S waves, so we call that an S prime, the second one. Now imagine that we also had another wave that came up again. We would call this R double prime. So how you read these complexes, it's an RS R prime complex, and this would be an RS R prime S prime complex. Okay, before leaving this slide, let's just review this one more time because this always comes up as an area of confusion. So here we have a P wave. If it deflects down first, so if this is negative first, so here's our P wave, we can call it a Q wave. However, if we have our P wave and then it reflects positively first and then back down, this is an R wave, but this down here, as it crossed our baseline, is considered an S wave and not a Q wave. So the S wave is defined as the first negative deflective wave after an R wave, whereas the Q wave is defined as the first negative deflective wave after a P wave. Okay, hopefully that makes sense. Let's move on. Okay, so we're still looking at the QRS complex, but we're going to look at the Q wave significance, because you may have heard that Q waves may be a sign of dead myocardial tissue, and this depends if the Q wave is significant. And Q waves are significant if it is 0.03 seconds or wider, or, so it's either one, so it's either this, 0.03 seconds or wider, or the Q is greater than 1/3 of the height of the R wave. So here's our Q, and if this is greater than 1/3 of our R wave, so this being our R wave, the positive deflection. So as you can see here, this is probably comes to about right here, so it is greater than 1/3 in this case. And again, it only needs one of these criteria to be a sign of myocardial infarction to that region to have significant Q waves. Now, if it does not meet this criteria, it is considered insignificant. Insignificant Q waves are commonly found in leads 1, AVL, and V6 from septal innervation, and therefore are commonly referred to as septal Qs. One last aspect of the QRS complex we will discuss is the intrinsicoid deflection. The intrinsicoid deflection is measured from the beginning of the QRS complex to the beginning of the negative downslope of the R wave in the leads that begin with an R wave and do not contain a Q wave. So the criteria of this is, we said, 1, the QRS complex must begin with an R wave, and 2, so both have to be met, it does not contain a Q wave. Okay, so these QRS complex to meet and to be called an intrinsicoid. So this is our intrinsicoid deflection. So the beginning of the QRS complex to the beginning of the negative slope. So from here to here. Now the intrinsicoid deflection represents the amount of time it takes the electrical impulse to travel from the Purkinje system in the endocardium to the surface of the epicardium immediately under an electrode. So let's just draw that out. So here's our Purkinje system conducting to the endocardium, which conducts to the epicardium, and then imagine our electrode here. So it's going this way. And so this represents the time it takes the impulse to get from the Purkinje system all the way to the electrode. So it's that time portion that is called the intrinsicoid deflection. Okay, take a look at this table, and I'm showing the upper limits of normal. And note that here the intrinsicoid deflection is shorter in the right precordial leads, that's V1 and V2, compared to the left precordial leads, V5 and V6. And this is because the right ventricle is thinner than the left ventricle. So it takes less time, as we said, to get, so from the Purkinje system to that electrode. The right ventricle is thinner, so the impulse will get through it faster, making the time lower. Okay, so if the intrinsicoid deflection is longer in the left precordial leads, that is V5 and V6, because the left ventricle is thicker than the right ventricle, can you think of any circumstances in which we would see a prolonged intrinsicoid deflection? Well, one potential circumstance may be from a thickened myocardium, as in ventricular hypertrophy secondary to hypertension. In this case, the thickened myocardium can prolong the intrinsicoid deflection. Another possibility could be when it takes longer for the electrical system to conduct to an area of the heart. This could be from an intraventricular conduction delay, as in left bundle branch block. Anyways, don't get held up on this topic. Just remember, if the muscle is thicker or conduction to the muscle is impaired, the intrinsicoid deflection may be prolonged. That's more than you have to know at this point, and all we will say about the QRS complex for now. Let's move on to the ST segment. So the ST segment begins at the end of the QRS complex. So here, remember we said this is the QRS complex. The ST segment begins at the end of it and ends at the beginning of the T wave. So we haven't talked about the T wave, but this is the T wave. So it begins at the end of the QRS and ends at the beginning of the T wave. Also note, the point where the QRS complex ends, so that's where this ST segment begins, is called the J point. So right here, this point here where the QRS complex is ending and then the ST segment is beginning, that's called the J point. Now, it's just important to note that the J point is not always easy to discern because of ST elevation. The ST segment is considered an electrically neutral period between ventricular depolarization, our QRS complex, and ventricular repolarization, so this part here, our T wave. And this period represents the time that the myocardium is maintaining contraction in order to push the blood out of the ventricles to the rest of the body. So just as our PR segment, which was here, the ST segment is found normally at the level of the baseline, our baseline here. However, there can be some normal variation of up to 1 millimeter from baseline in the limb leads and up to 3 millimeters in the right precordial leads, that's V1 and V2. And this can be caused by left ventricular hypertrophy or early repolarization patterns. We won't get into too many details at this point, but just know they may exist as normal variants. Always remember that the clinical picture is key for making any diagnosis. With that said, if there is any sign of ST elevation in a symptomatic patient, it should be considered significant for myocardial injury or infarction until proven otherwise. As referred to briefly in the previous slide, the T wave here represents ventricular repolarization. It is the next positive or negative deflection after the ST segment. So here's our ST segment from the end of the QRS to the beginning of the T wave. And in this case, it's coming up, so it's a positive deflection. So this first positive, or it could be negative deflection after that segment, is considered the T wave. One thing to note is that the T wave should go in the same direction as the QRS complex. Now this seems strange at first. Wouldn't you think that the QRS complex, so here's our QRS complex, which is ventricular depolarization, would go in the opposite direction as our T wave here, that is ventricular repolarization? That is to say, shouldn't the cells first depolarize be the first to repolarize? It may seem so, but this is flawed. If you can recall from one of our early lectures on the electrical conduction system of the heart, as the electrical current makes its way through the conduction system to the Purkinje fibers, it then depolarizes the myocytes in the endocardium and then moves out towards the epicardium. Now, because of the increased pressure on the endocardium during contraction, the repolarization wave travels in the opposite direction, that it goes from the epicardium to the endocardium. So let's review that. The wave comes down, depolarizes the Purkinje system, we have our myocytes, the endocardium, and then eventually the epicardium. So depolarization is going this way, and repolarization is going in the opposite direction. And then imagine this as our electrode here. So let's label our electrode here. And it's important to remember that repolarization is a negative wave, and we'll have our depolarization is a positive wave. So if we look at this depolarization, because it's a positive wave and it's moving towards the electrode, we should see a deflection upward, which we do in the QRS complex. So imagine our QRS complex. And we have the repolarization wave, which is a negative wave going away. So when you think of going away, I want you to think of that also as a negative wave. And when we have a negative wave, our repolarization wave going away from the electrode, this also produces a positive wave. And that's why our T wave is upright. So sometimes an easy way to think of this, if the wave is going toward, consider that a positive. If it's going away from the electrode, make that negative. If it's depolarization, consider that positive. If it's repolarization wave, think of that as negative. So now think of our QRS complex representing ventricular depolarization. So we have a positive wave moving toward an electrode, also a positive wave. If we multiply those together, we get a positive, and this is what we will see on the EKG. And now if we have a QRS complex, if we now look at the T wave, which is a repolarization wave, right? And we said repolarization is negative, and in this case it's going away from the electrode. So negative times negative is positive. So on the EKG, we will see both a positive QRS complex and a positive T wave. So the key thing to remember is that a normal T wave should be in the same direction as the QRS complex. And also keep in mind that there are exceptions in some pathological states. So let's look at the symmetry of the T wave. So here's our T wave, and what we're going to see is that the T waves should be asymmetrical, with the beginning of the T wave rising or dropping slowly, slow rise as you can see here, and the end of the wave moving much faster. So in this way you can see a faster downstroke in the end of the T wave. In order to assess for T wave symmetry, first find the peak of the T wave. So if we imagine this is our T wave, find the peak of it, then draw a perpendicular line from the peak to the baseline, and finally compare the two sides up for symmetry. So as you can see here, this is asymmetrical, and this is what we want. If you look at the one on the right, here's our highest point, come down to the baseline. These are both symmetrical, both sides of the T wave. So these two here, these asymmetrical T waves, these tend to be normal. Whereas if we see symmetrical T waves, these tend to be a sign of pathology. The QT interval begins where the PR interval ended. It includes the QRS complex, the ST segment, and the T wave. So here, as we said, is our QRS complex. So here's our QRS. Here is our ST segment, and this is our T wave. So that's from the beginning of the Q wave to the end of the T wave makes up our QT interval. It represents all of the events of ventricular systole, from the beginning of ventricular depolarization to the end of ventricular repolarization. So the beginning of ventricular depolarization, our QRS complex, to the end of ventricular repolarization, the end of our T wave. The QT interval can vary for many reasons, including age, sex, heart rate, and electrolyte abnormalities. It should be less than half of the preceding RR interval. We will discuss the RR interval towards the end of the lecture, but it's simply the interval between the peaks of two R waves. So if we imagine here's an R wave and here's an R wave, and it's simply that distance. This is considered the RR interval. And we'll look at an image of the RR interval as well as the PP interval in a later slide. You may have heard that a prolonged QT can lead to arrhythmias, and that's true. The most commonly tested one that is life-threatening is torsades. So that's one to look out for. Somewhat uncommon, but it's highly tested. So we said in the previous slide that the QT interval changes with heart rate. That's to say, if we increase the heart rate, the QT interval will lessen. And also, if you decrease the heart rate, we will get a prolonged QT. And that's to say that the heart rate and the QT interval are inversely related. Due to this variation of the QT interval with heart rate, QTC interval, which stands for QT corrected interval, attempts to correct for this variation. And we have this equation here on the slide in red. So the QT corrected interval is the QT plus 1.75 times the ventricular rate minus 60. And you really don't need to know this equation because the value is often calculated for you by the EKG machine. And a normal corrected QT interval is about 0.41 seconds. And anything greater than 0.419 seconds is considered prolonged. And the last wave we're going to discuss is the U wave. And this is a small flat wave that appears after the T wave. So here's our T wave, and it's appearing after it, and it appears before the next P wave. So here's our first P wave, and it's appearing before the next one after. It is not always seen and unclear what it truly represents. It is often benign and often seen in the setting of bradycardia. It may also be a sign for hypokalemia. Now there are two clinically relevant points to remember about U waves. One is that there's no possibility of hyperkalemia if a U wave is present. And the second point is it can cause an inaccurate measurement of the QT interval, in which the EKG machine includes the U wave in the measurement of the QT interval, making the QT longer than it actually is. So sometimes the machine will pick up and combine these together, so this whole interval together, this whole QT interval, and make it seem like the QT interval is longer than it actually is, but in fact you have a U wave present. So when you see a prolonged QT interval on a EKG strip, make sure you check for that U wave. The EKG machines, are often, they could be wrong too. So make sure, that's not there before saying that a patient has a prolonged QT. Let's end this lecture with discussing a few common intervals that you will often hear about. First, the RR interval, which is simply the distance between the R waves of two consecutive QRS complexes. So here in the image we have one QRS complex and the other, and it is the interval between them, specifically from the top of the wave, which is an R wave, and this R wave of the QRS complexes. So that RR length is called the RR interval. And we use this to evaluate rhythm. The rhythm is considered regular if the distance between the RR intervals is consistent throughout, and it's irregular if it's not. So let's just show that quick. Here is a few complexes. Imagine that the distance between all of these, I know not exact, but imagine that they're both consistent. Let's just label them as 1. And then we have this complex here that shows something like this. And now we can see really the distance between this and this. Let's label that 0.5. They're not the same. So we would call this second one an irregular rhythm and this top one a regular. We'll get into more of regular and irregular rhythms in future lectures, but just to give you an idea. And it's looking at that RR. So just know that the RR of the QRS complex is called the RR interval. The other interval we will discuss here is the PP interval. And this PP interval is the distance between two identical points on one P wave to the next P wave. So again, here's one P wave, here's another P wave. Remember, this is a T wave in between, not a P wave. So it's the point from here, the same point. That space, that distance in between is called the PP interval. And this is useful in evaluating for rhythm abnormalities such as Wenckebach's second degree heart block, atrial flutter, and third degree heart block. So the main thing of this slide is just to know what is the RR interval. So the distance, or this length between the R wave of one QRS complex to the next one, and the PP interval from one P wave to the next, the same point. That's the PP interval. Alright, well, that was one of our longer lectures. Great job on getting through it. It can certainly be confusing and overwhelming keeping the names of each aspect of the complex straight if this is your first time. Make sure to go back and review the key points on each slide. Watch the lecture over again. Repetition is key to mastery of any topic, including this one. Keep up the hard work. The fun is just getting started.